Hello, everyone. I'm Philip Osteen, Dean of the University of Utah College of Social Work, and it is my pleasure to welcome you to today's Social Work Beyond the Classroom event, supporting primary care patients in self-managing opioid addiction, mental health, and chronic disease, presented by Dr. Elizabeth Siantz. This series creates room for ideas that travel beyond the classroom, where research and practice meet in service of community impact. Whether you're participating live or viewing this recording later, we're grateful for your engagement in this conversation. Dr. Siantz is an assistant professor here in the College of Social Work. She is the principal investigator of a 5-year Mentored Research Science Development Award from the National Institute on Drug Abuse, or NIDA. With this grant, she's studying the adaptation and implementation of a peer-led chronic disease self-management program for primary care patients with opioid use disorder and serious mental illness. Dr. Siantz is also a VA-funded Implementation Research Institute Fellow at Washington University, St. Louis, and is supported by a NIDA loan repayment program for health disparities research. In today's presentation, Dr. Siantz will discuss her research on implementing the chronic disease self-management program in primary care settings focused on substance use disorder treatment. Following the presentation, we'll have time for audience questions, so please feel free to submit your questions at any point during the session by using the Q&A feature at the bottom of your Zoom window. And with that, Dr. Siantz, the screen is yours.
Thank you so much for the introduction. And thank you everyone who's joining me today. I'm just going to jump right in. I'd first like to take a moment to thank my team and my supporters, particularly my research assistants from the College of Social Work here, my collaborators from the University of Utah College of Health and School of Medicine, and the VA. And then also, I'd like to thank my mentoring team, particularly my co-mentors on my KO1 grant that Dean Osteen just told you about, Dr. Adam Gordon and Dr. Leo Cabasa at WashU. So what will we cover in today's talk? So first, I'm going to say hello and reintroduce myself since I haven't, as I was preparing, I realized I hadn't given a talk like this to colleagues here at the college since I gave my job talk in 2019. So this is a really delightful opportunity to reintroduce myself. So I'm going to give a hello and reintroduction. I'm going to give an overview of my research project and rationale. I'm going to share with you the qualitative results from specific aim 1, and then just kind of share some of the next steps that I have on deck. And then, of course, Q&A. So, hello, just a little bit about me. As Dean Osteen mentioned, I'm an assistant professor here in the College of Social Work at the University of Utah. I'm a faculty affiliate at PARCA, which stands for Program for Addiction Research, Clinical Care, Knowledge, and Advocacy, which is a really wonderful group of researchers and clinical providers here at the University of Utah that focus their work on addiction research and care. And then again, I'm also an Implementation Research Institute Fellow, which I'll actually share more about that in just a minute. And then my professional mission is to promote health equity, quality of life, and quality of life among persons with multiple chronic care conditions. And so kind of throughout my, the last 15, 20 years of my career, that's really included, or focused on rather, people living with serious mental illness and chronic disease. And within the last few years, that has sort of expanded to include people in recovery from opioid use disorder. And so I am promoting health equity and quality of life in this population by implementing self-management supports across a range of service environments. So some of this examples of this are peer support specialists in multicultural service settings, the Spanish and immigrant serving human service organizations, and chronic disease self-management education, which you're going to hear a lot about today. And I study these things using mixed methods and qualitative study designs and the theories and models and frameworks of implementation science. So the sort of the utility and versatility of self-management educational resources is really a long-standing interest of mine that dates back kind of to the earliest parts of my predoctoral training. And so this is a screenshot of my first publication as first author in 2014. So in this systematic review, I learned that chronic disease self-management programs delivered by, or when delivered by peer support specialists, can improve patient activation, primary care service use, medication adherence among program participants with serious mental illness compared to usual care. Following that came my discovery and engagement with the field of implementation science. So what is implementation science? It's the study of how to make sure that empirically supported practices are used in real world settings and that they work well for the people and the environments that they are intended for. So starting with kind of like just a little more of my backstory. Back in my dissertation research, I explored the roles and social network positions of peer support specialists in integrated behavioral health settings, where we found that peer support specialists are not actually implemented very well, if at all. Later, as a postdoc, I served as a project director in a large initiative to integrate behavioral health services and primary care services, just kind of to understand implementation, challenges and successes and so forth across different service delivery contexts. And then, a scoping review of practice facilitation as an implementation strategy to support the integration of behavioral health and primary care services. So my knowledge surrounding these topics has recently sort of advanced and grown to include opioid use and addiction. And this was when I was kind of started here when I began working at the U in like 2021 or so, when I was brought in as a mixed methods implementation scientist and co-investigator on Jake Magel's R01 team, where we're studying the implementation of a mindfulness intervention for physical therapy patients who have chronic pain and use opioids. And then from there, I kind of like really leveled up to the next kind of tier in this by joining the Implementation Research Institute at Washington University in St. Louis. So that's been a really wonderful experience to engage with these topics on like on a deeper level. So the theme of implementing self-management resources has continually emerged across my different eras. And so that's really led me to think, would the chronic disease self-management program work for people with serious mental illness and substance use disorders, right? What about opioid use disorder? What would it take to implement this program in, different types of care environments? Okay. And then, so just to give a little bit more context on this presentation, so in 2023, I was awarded, a mentored career development award from NIDA to study this, right? So it's a training grant and it's a research grant. In this talk, I'm going to focus pretty exclusively on the research side, but if anyone's interested in the training side, please, feel free to reach out. And so this is what I'm going to tell you about next. So why this? Why people with opioid use disorder over others that also need self-management support? So in the US, there are, about 100,000 overdose deaths per year, and about 75% of them involve opioids, which has made opioid addiction, and overdose the focus of a lot of national initiatives. And there's a lot of people focused on this right now. Let's see. And then also people with opioid use disorder have increased risk for serious mental illness, right? With national data estimating that about 27% of people with opioid use disorder, or OUD, as I might abbreviate it here and there, have a serious mental illness. And so that's schizophrenia, bipolar disorder, major depression, and so forth. So estimating that 27% of people with opioid use disorder have a serious mental illness compared to 4% of the general population. And then having an opioid use disorder and a serious mental illness, it just increases risk for, a number of social vulnerabilities, as you can imagine, such as homelessness, poverty, justice involvement, and unemployment, and increases risk for also having other chronic care conditions that need to be managed, right? Okay, but there are few provider tools or evidence-based treatments for serving this population, of people that are living with opioid use disorder, serious mental illness, and other chronic diseases. So, taking a step back, primary care is the first place that people go to for most of their healthcare needs, right? For routine checkups, for management of common or chronic illnesses, for preventive care and referrals. And the right primary care setting can improve access to medication-assisted treatment. And this is especially true with the elimination of the X waiver, which providers once needed to prescribe Suboxone or medication-assisted treatment. So the right primary care environment, it really can treat patients with mild to moderate opioid use disorder. It can improve access, as I mentioned, and it can provide this longitudinal treatment approach in a supportive care environment. But primary care providers are challenged by limited time and training and resources that can really address the needs of people living with opioid use disorder and, co-occurring chronic care conditions. So, the Chronic Disease Self-Management Program is a 6-week group educational program that is led by lay community health workers. It was originally developed by Kate Lorig at Stanford University, and it's widely used in general medical populations and has improved self-management, behavior activation, and clinical outcomes in general medical populations. And also, just as an aside, a team of RAs and colleagues and I are conducting a scoping review right now of the chronic disease self-management program or adaptations to this program across like different cultural and clinical contexts. And I can say with great certainty that it is widely used. Okay, so and the kind of some of the three sort of foundational programmatic assumptions, I guess, on this chronic disease self-management program is that people with chronic diseases share common self-management challenges, regardless of what the chronic disease is, right? Everyone has to manage their disease. People can learn they can learn skills to own their disease management, right? They can become more skilled and more confident in doing this, in managing their diseases, and talking with providers, and taking their medication, and connecting with community, and navigating pain management, right? And the third assumption is that skilled and empowered people will demonstrate improved health and consume fewer healthcare resources, which makes this an especially popular program. And I also meant to hit that trend or animation earlier. So self-management, I'm just going to provide you with an operational definition before it's too late. So it's just one's ability to live a healthy life with chronic conditions. It requires use of skills to manage the work of living with the chronic illness, continuing daily activities, and dealing with the emotions that are brought on by an illness, right? So that can feel like depression, that can feel like some negativity, that can feel like, oh, I don't want to do that today because it's too hard. And so self-management skills can include these activities here that are, or these skills rather, here in the self-management toolbox. So we have physical activity, we have decision making, we have action planning, we have breathing techniques, communicating with providers and with others in your life. And then I think kind of one of the ones I'd also like to underscore here is this notion of problem solving, right? So making an action plan and problem solving how to best achieve an action plan is kind of a cornerstone of the chronic disease self-management program. And if you think about it, for people living with opioid use disorder, self-management skills are really, they're critical, right, for addiction recovery, and are needed to change old habits and routines that have led to recurrent drug use. So self-management tasks that could be specific to opioid use disorder could include attending behavioral therapy and medical appointments where they might receive medication treatment for opioid use disorder, developing new personal relationships, just as some examples. But the question then becomes, can we implement a chronic disease self-management program in a primary care setting that serves patients with opioid use disorder and serious mental illness? So some considerations without even before having done this work, there were just some obvious considerations. What if providers don't understand the utility of the program, right? What if people want to educate patients themselves? So, from, patients, what if they need actually a higher level of skill development to kind of follow medical device or like require education on specific topics? So we don't know. And so okay, so as I mentioned, the work I'm kind of telling you about right now is part of a larger project, right, with three specific aims. The first aim is to adapt and learn how to implement the chronic disease self-management program for adults with opioid use disorder, serious mental illness, and chronic disease for a primary care setting. And this is going to be done using a qualitative multi-stakeholder approach. The second aim is then to test the feasibility, acceptability, and initial impact of the chronic disease self-management program in a primary care setting through just two small randomized pilot trials, which I'm just going to hold off on saying more about that for the moment. And then the third aim is a qualitative implementation evaluation, where I'm working, where I'm learning how to, do a such an implementation evaluation using a method called RAPIS, which stands for Rapid Assessment Procedure Informed Clinical Ethnography. So the idea is that you go into the sites and you get to know the clinical team really well, and you understand how the intervention is how it's going, right? And you just get to know how it's going using ethnographic methods. And so I'm working with a medical anthropologist to learn how to do that, which is very exciting. So, okay, so in this talk, I'm going to focus on this first aim because that is the aim. This is kind of where I'm at currently, is towards the end of this aim and transitioning into the second one. And as I mentioned, so I'm learning a lot I'm learning a lot doing this project. And as I mentioned in my, you know, re/introduction, I do have the most expertise as on qualitative and mixed methods for implementation science. So learning how to conduct a clinical trial it's been very educational. And one of the things that I've learned is that you really just have to learn by doing. And so that's my next step. Anyway, so that's just an aside. And then, okay, so the research question is that I'm going to explore with you guys, for the next 20 or so minutes, is how do primary care patients with opioid use disorder and serious mental illness self-manage their chronic conditions? And by understanding that and their self-management successes and their self-management challenges, that can help providers, the provider community and the research community understand how to better support this patient population. Okay, so study questions for this aim, where I'm learning how to adapt this and seeing if it's possible to implement a little bit of pre-implementation phase, right? So it's just learning how to implement it across two clinics. How do patients self-manage their chronic conditions? What are their barriers and facilitators what are their self-management barriers and facilitators? Would patients engage with the chronic disease self-management program? Why or why not? Yeah, and the goal is just to understand if any, what if any adaptations are needed. So this study is occurring at two addiction-focused primary care clinics, local here to Salt Lake City. One of them is a university primary care clinic known as the Spark Clinic, which stands for Supporting Patients Through Access, Research, and Continuity. And then the other is a VA primary care clinic called the Vulnerable Veteran Innovative Aligned Care Team at the VA Salt Lake City. Okay, these settings are addiction focused. They're patient-centered and they're harm reduction oriented. So, according to one provider, we offer injectable medications, and there's a lot of teaching about that, a lot of harm reduction education's happening at these clinics. And because, right, and relevant to this, the current project is because we do primary care, it's just like everything else too, right? People come in with all kinds of conditions. They are sort of run by a multidisciplinary care team that includes an MD, a nurse care manager, social workers, of course, pharmacists, and both have peer support kind of available on site or like close, nearby, anyways. And then they're both situated in a very pro self-management organizational culture. Um, right. So one of the settings has a peer-led recovery group. Another one has a provider that themselves leads a healthy lifestyle group with VA patients. And also kind of relevant that they're both situated within these very comprehensive healthcare facilities, right? But the university system and the VA system are very different, of course. So to recruit for this study, I first began with primary care staff and provider interviews. I kind of did for anyone who does qualitative research in human service organizations, they know those people will know the drill, how you present the project at a weekly team meeting, you engage with people over email, you kind of start showing up, getting on people's good side, that kind of stuff. So providers were recruited on site and over email with the support of, people on my team that were chronic disease self-management program enthusiasts. And then the patient participants, so those interviews happened first. And then the next phase were the patient participants, right? That was a little bit more complex, right? So providers identified patients that had a chart diagnosis of opioid use disorder, and then a chart diagnosis of a serious mental illness, such as schizophrenia, bipolar disorder, major depressive disorder, PTSD, or severe anxiety. Often people have more than one. And then during their scheduled appointment, providers shared the option of participating in a qualitative interview in my project. And then the patients communicated through their provider if they were interested and if they wanted me to contact them for study recruitment. What else do I want to say about that? Was a very interesting, again, since it's training ground, there's a lot of learning that happened. And so I've never done a research project with the VA before. And so there are quite a few things that have to happen to conduct a research project at the VA. So I feel like I'm not even I'm just telling how recruitment went. There was a lot that happened behind the scenes. So again, but happy to share about that if anyone else is considering doing research at the VA. Non-VA people, that is, considering doing research at the VA. Okay, so what did we ask people, or what did I ask people? Because I conducted the interviews myself. So provider and staff members were asked, what are the main self-management needs of patients? What makes it challenging to support these patients? And then in terms of, right, so this is the pre-implementation, right, of the with a future implementation of the chronic disease self-management program. So asking people after, reviewing program materials and so forth. What are 3 things that make sense about the chronic disease self-management program, and what are 3 things that don't make sense? Okay, and so then the patients were asked, what are your main health needs? And of course, probing for substance use and addiction, mental health recovery, and chronic disease, asking patients to describe their understanding of what's causing these health needs, what's causing these health needs. And note that the patient interview, I did my best to follow Arthur Kleinman's explanatory model for illness, which is just sort of like a quintessential, medical anthropological um, interview guide for basically to understand a patient's understanding of their illness. Okay, so what's causing these health needs? How do you manage your health? And then after kind of giving an overview of the chronic disease self-management program, what would motivate you to participate? So I followed a rapid content analysis, which is basically, so it's a qualitative analysis, but it's it's a streamlined way of reviewing interviews just to quickly identify the main themes and patterns. And I know that this kind of is counterintuitive to, some more traditional approaches to qualitative research, but it's very useful for when it comes to program implementation or when you want to be very focused and move quickly on a project. Okay, so essentially you decide ahead of time what you're looking for and you develop a structured template. And so it's a little positivist, but I think that there were trade-offs, right? And I think this was ultimately a really useful approach. And you just organize the summarized content according to these um, categories that you come up with ahead of time, summarize key points. And then, for example, we were looking at all content related to patient needs were summarized and with exemplary quotes to support whatever assertions we were making about the data. So I had a lot of help from two RAs, Emily Rougelot and Megan Richards, who helped me digest this data in a really efficient fashion. Okay, so sample characteristics. Um, So I spoke with uh, 9 providers. They had a range of disciplines, as I mentioned. They were about half from the University of Utah, half from the VA, mostly Caucasian, average age in like the mid 40s. Average age had been practicing for like 7 to 10 years, with some much less than that, some a lot more than that. And then with the patients, I spoke with about 18 people, mostly men, generally high school education or a bit more. All had a chart diagnosis of opioid use disorder, also mostly Caucasian. Most were not employed, though a few were retired or on disability. If there's anything else I want to say about that. Okay, I'm going to move on. So I'm going to tell you the way that the next little bit is going to go is that I'm going to tell you first about what the patients reported about their experience with self-management, and then I'm going to go into the providers and then kind of some lessons learned and then wrap up from there. So patient experience with self-management. So first, I just want to say that the patient participants discussed having a lot of complex health needs, and this included mental health conditions such as anxiety, depression, schizophrenia, PTSD, substance use and addiction challenges, a lot of chronic diseases as well, chronic kidney disease, diabetes, hypertension, hepatitis C, along with assorted physical symptoms. And so with regard to how they self-manage these conditions, people spoke a lot at length about medication-assisted treatment for opioid use. Noting that since I've gotten on the Suboxone shot, that really helps with cravings. And if I use opioids again, I'm going to get really sick, right? A lot of medication for seizures, chronic disease, smoking cessation. People spoke a lot about being active with community and with family, right? Going to church, recovery meetings at their church, reflecting on how their family holds them accountable. I have, as one person said, I have some really bad days. I'm depressed, and the thing that's got me moving on was like, hey, you've got these kids to take care of that love you, and you have a family. So, reflecting on how positive, the positive people in their life really hold them accountable. And then another kind of self-management activity that people were engaged with was engaging with their healthcare at their primary care clinics where they were recruited from. And one person kind of summed up everyone's overwhelmingly positive feelings about being involved, receiving care at these places by saying, I feel loved. So with regard to self-management challenges, patient participants reported that they were challenged by coping with symptoms of mental illness and addiction, right? Someone said, everything's pretty much a struggle, cycle of anxiety and withdrawal and fear. You get pain from injuries and then that depression and it hurts. So people really did share their struggles. People were challenged by navigating healthcare bureaucracy, and that was true across the VA and the university setting. People also spoke about their challenges with negative influences from their social network, right? So as one person said, my girlfriend is hooked with blues and crack and all these crazy things. I had an apartment and everything, was doing good. But as soon as she moved in with me for about a year, we lost everything because she was, she was so bad about it. With referring to her own addiction challenges. Other challenges included just following medical advice while unhoused or incarcerated, and then pain management is difficult within the context of addiction recovery because oftentimes people were prescribed opioids for something related to pain and are still having to deal with that. So, what would I work on in the chronic disease self-management program? And people had a few things that they were planned that they would theoretically plan to work on if they were going to be involved in this moving forward. So communicating with providers and navigating with systems of care, that was a fairly prominent one. Um, Finding out how to convince, their GI doctor that I actually do have a problem. That someone actually has already started improving their self-management journey by making a list when they have things they want to talk about during an appointment. That people were interested in working on healthy eating, right? One participant made the comment about how, like in addiction recovery, that this is what it's known as putting down the spoon to pick up the fork, right? That people are replacing, replacing addiction with eating unhealthy food. It was something that came up across a couple of different interviews. And as another person mentioned, that, I didn't realize how much I didn't really eat sugar when I was drinking. Um, and so when you're getting sober, like that's when you realize that like you are starting to take on some unhealthy habits is kind of the essence of that. And then other wellness goals included exercising more, finding employment, managing anxiety, and then, as someone very sort of seriously mentioned, wrapping my head around the fact that if I don't do this, engage in these health activities, these self-management activities, I'm going to die. So there was some really serious undertones to these conversations. So provider experience with supporting patient self-management. So, patients reported on their own experiences with self-management, and the best providers, of course, can do is discuss their own understanding, right, of patient self-management experience. And so their understanding is that people have a lot of competing demands, right? So I've got to find a place to sleep tonight, and so that's very important. Maybe more important, as the quote goes on, that than picking up my prescription for my hypertension or remembering to take my diabetes medication. And so it's this kind of hierarchy of needs, right, that can really impact a person's ability to make healthcare a priority. Transportation, housing stability, just these extra things, they can really impact their ability to make healthcare their priority. And then, of course, just management of multiple conditions is taxing, right? They're already maxed out, I guess, depending on where they're at in their sobriety. And so their challenges with supporting patients, their observations that they shared were, kind of the following: that patients were challenged to engage with health education materials. They just kind of felt there's like a little bit of an undertones of discouragement here, I would say, right? They're challenged to teach self-management skills within the patient's hierarchy of needs, as I said. So because there's so many things, or maybe priorities, I'm reading the second quote here, or maybe they have somebody living in the car, homeless, and not having any time, and seeing when they're going to get the next meal, and surviving this crazy winter that we're having. If I talk about kale, it's stupid, right? So thinking like, well, they have other things to worry about besides like healthy eating. Um, and then they're just general challenges in supporting patients across numerous conditions. We're dealing with 10 to 15 diseases, 12 to 20 or plus medications for a patient. So kind of it's hey, so individualizing each disease and saying, hey, here's how you think about managing this disease. So it's so impossible to do. And as someone else comments, self-management is the largest problem in primary care. Okay, so the things that make sense and that don't make sense, right? We have from the provider perspective, continuing with a provider perspective, things that make sense. Peer support, right? There are things they want to talk about that they don't need to talk about with their provider. Sometimes things can be personal. The toolbox, remember the toolbox I showed you guys earlier? Right. So the opportunity for learning, like individualized thing, like things that they can work on, things will be different things will be useful for different people. Breaks down self-management into skills that are not abstract. Uh, and also in this idea that for this particular population, harm reduction, being harm reduction based versus abstinence based, right? That's obviously something that's important. So things that don't make sense, people have a million competing demands. You can't treat life pain with metformin. There's a bit of a time commitment. Just a little bit of uncertainty about like, will everything be relevant for everyone, or like, how does this work? And then, of course, some logistical challenges, some concern that like, well, people might not show up, or like, what happens if people don't show up? So there's just some logistical challenges like that. Um, but I also want to say that providers were, in general, quite enthusiastic, well, as were the patients, were quite enthusiastic about the possibility of this being implemented at their service setting. Okay, so what next? So I just want to pause and reflect here for a second. Um, that, patients and providers together, the participants really provided a very rich perspective on how to support self-management of primary care patients with opioid use disorder, co-occurring mental health conditions, and assorted other chronic care conditions as well, right? So patients described a lot of complexities in their lives, and I feel like it's kind of hard to, in this format, like really dive in and kind of share the complexity of the human experience, right? And I feel like as social workers, that's sort of what we know about, that like it's complicated. Um, so patients several were engaged with community, several were being held accountable by their families. Several had complicated relationships with family members and partners and so forth. Providers had they gave there's a lot of value to what they were saying as well, because they contributed a really broad professional understanding of what challenges their patients, right? And so they took sort of a wider lens of understanding the the terribly challenging context that people are living their lives. There's homelessness, there's living in your car, um, not being able to navigate between these like really complex health systems. So those are kind of like some of the weaving together, right? These two perspectives, and to yeah, just sort of wrap up with some implementation suggestions that really came out from all of these interviews, right? Patient engagement, peers are going to be critical for engaging patients. At the VA, the overwhelming consensus from everyone was that the peer facilitators really do need to be veterans. Patients like spending time with other veterans. Um, as another patient participant said, I like to spend time with other veterans. Camaraderie, I like the camaraderie and learning from other people's experiences. This idea that maybe there should be some positive feedback like contingency management. So contingency management is a structured way of using positive incentives to support behavior change, right? This is commonly used in addiction care, and is basically just rewarding someone when they meet a goal. So maybe that's an important approach for working with this patient population. And then in terms of patient engagement, like that, remember that logistical challenge I mentioned, delivering content to patients, like how are we going to deliver content to patients who miss a session? And honestly, this is sort of the main protocol deviation that I think is like kind of come up from this pre-implementation work, that we're kind of need to maintain fidelity, obviously, but there are special considerations for a group of people that don't have reliable transportation and still really want the content. So provider engagement, providers might actually just need more information about the program. They might want to know if the patients are participating, so that can like add some complication for like who tells them that, like the patient can tell them that. I would need IRB, I would need like special IRB consideration were I to tell them that. So some considerations. Um, so the providers were uncertain as to whether the session length was a good one. I recognize that they are long, but this is people do this. I mean, this is like like a very widely used program. So 6 2.5 hour sessions, that could be kind of a lot. But again, the patients had a high level of enthusiasm. So virtual versus in person, the patients were like hands down, we want to be there in person. We want to be together. But the clinics have limited space. So as I'm moving to the next step, it's like, okay, I need to like really figure out where these programs will be delivered if there's not space at these clinics. How's that going to work? And then of course incentives for attendance. Okay, and then this is kind of my last thing, just the next steps. So I got these two pilot trials coming up, one at the VA, one at the university clinic. That's under IRB approval right now. And that, based on my experience, this will not be a fast process. So that is to be continued. And then during the feasibility trials, there will be a simultaneous clinical ethnography evaluation of the implementation of these programs. And with 1 minute to spare, I'm going to leave it at that and say thank you. Um, and that's all.
You hit it like right on the button.
I,
12:45. Good
yeah,
job.
look at that. Patting self on back.
Thank you so much for the presentation. And as I was saying before we started, as someone who's just not familiar with your work, it was really great to have that. So thank you so much. So we'll move into Q&A. We already have a couple of questions, but if you have a question for Dr. Siantz, please go ahead and put it in the Q&A. The button's at the bottom of your screen, and then I'll help moderate some of those. So let me start here. So first question, in the data analysis, was that all based on the template or oral reports of subjects?
Based on the template or the reports of subjects.
Yeah.
Okay. Well, the template really is the um, consists of the reports of subjects. So, right, because we did the template analysis, we knew what we were looking for. So we were pretty focused on that. There was a little bit of flexibility to add new things that came up. But all of that was populated by exact quotes from the study participants and with our interpretation of participant quotes, as is pretty standard in qualitative research.
Okay. Next question. To you, what was the most surprising finding in the study?
Ooh, I love that question. The most surprising finding, well, I feel I'm going to preface this by saying that I talked to a lot of providers and a lot of clinician scientists in advance of this project. And it was all just like so hard. There's so many things going on. And so to sit down and talk with patients, and it was such a gift to be able to do that, to sit and hear about people's experiences, to hear about people's like all of the wins that people had and like their act people like no, they like have self-management routines. And I feel bad saying that I'm surprised by that. But
Mhm.
again, it was just kind of the information I was given in advance of this project led me to a place where I was actually kind of surprised that people had so many things they were doing and engaged with as they're working towards their recovery journeys.
That's great. I did see a comment. I don't know where it went. Somebody was asking about recording. So everyone who registered will get the link to the online recording where you can obviously watch this again. You can also review the slides as part of that online recording. We don't normally send the slide decks out though. We only use them as part of the recordings. Any other last questions for Dr. Siantz before we come to the close? All right. So I want to thank you, Dr. Science, for offering us a look at how peer-led self-management can strengthen care for patients with complex health needs. Thank you to the communications, marketing, and event planning team, and to everyone who could join us today. Thank you for sharing your questions and your time. For those who are seeking continuing education credit, you'll receive an email in a few days with a link to the recording and a brief quiz. Once the quiz is completed, your CEU documentation will be sent to you automatically. We hope you'll join us again throughout the rest of the academic year as we continue to gather and learn together in community. Please visit the College of Social Work events page for information on what's coming up. Thank you again for being part of our social work community. Please take care of yourselves and those around you, and we'll see you next time. Thanks, Dr. Science.